This is NTV.
The United Nations has described the novel coronavirus pandemic as the, quote, defining global health crisis of our time. Well, it has been 77 days since the first case of the coronavirus was announced here in Kenya. And today, the novel COVID-19 has infected 147 more people in the country, raising the total number of cases to 1,618. The virus has also claimed the lives of 3 more people, putting the death toll at 58. And 2 months ago, the World Health Organization Director General said that his biggest concern was COVID-19 spreading in countries with weak health systems. And Kenya is among those countries in the world with an already overstretched system. Good evening and welcome to the Nation Leadership Forum. I'm your host, Smriti Vidyarthi. Tonight, we question how the country's health system is coping with the rising number of infections, whether or not we have the capacity to manage the worst case scenario, and how we're safeguarding the welfare of those battling at the front line during this pandemic. Joining me to answer these questions are my panel, and that includes Dr. Mercy Mwangangi. She is the Administrative Secretary at the Ministry of Health. Also, Dr. Chibanzi Mwachonda, the Acting Secretary General of KMPDU, that's the Kenya Medical Practitioners, Pharmacists and Dentists Union. Sean Buluki, he is the Chief Executive Officer of the Aga Khan University Hospital, and also Dr. Githinji Gitahi, the Group CEO of Amref Health Africa. Thank you all for joining us on the Nation Leadership Forum, and you too can join the conversation online. Tweet us at Smriti Vidyarthi at NTV Kenya and use the hashtag NMG Leadership Forum. Dr. Mwangangi, I'll start with you. And the infectious nature of COVID-19 has put enormous pressure on an already strained healthcare system. From the Ministry of Health's assessment, how has COVID-19 impacted Kenya's healthcare system thus far?
Thank you, Smriti, and thank you for providing this opportunity for us to share with Kenyans our current progress in the COVID-19 response. And perhaps for me to start with saying that the impact of COVID-19 is exactly what we're seeing here today. Having to have an interview, transmitted through online mechanisms, and, being able to do things differently. When we look at the healthcare system in Kenya, we've had indeed effects of COVID-19 impact spreading across different sections in terms of service delivery. One, the biggest thing is that COVID-19 has required us to actually spotlight public health security. This has now become a key important element in ensuring that Kenyans are secure and that we're able to have strong surveillance mechanisms. And then most secondly, we've had to readapt how we do things, how we ensure that mothers are still able to get the care that they need in terms of delivery services, in terms of antenatal care clinics, and ensuring that children are also getting the immunization services. This has required a complete overhaul into how service delivery is conducted. One, there's been stigma, fearfulness from Kenyans in terms of being able to seek the healthcare services that they require. And so the ministry has had to relook at seeing how we can actually encourage Kenyans to seek the healthcare services that they need. And secondly, we're seeing that within the National Hospital Insurance Fund, we are now getting fewer subscriptions. Indeed, COVID-19 has had an impact when it comes to our economy, when it comes to our ability to be able to pay for health insurance. And so we're seeing these effects actually permeating through different elements of the healthcare system. And I think I like what you said earlier when you made your introduction. Are we ready for the worst case scenario? And what is the impact, in fact, of the current numbers that we have? And indeed, I can say that we are working, collaborating with members who are on this panel. We are working closely with non-state actors, working also with different ministries, departments, and agencies to ensure that our COVID-19 response is actually agile and it's actually able to give us the results that we're looking at.
Right, well, we
Thank you,
will
Smriti.
certainly delve deeper on that particular issue as to how prepared we are. Dr. Chibanzi, I'll bring you in now. And COVID-19 has certainly exposed the weak links in Kenya's healthcare system. There certainly are gaps. You are working with people who are physically on the front line when it comes to fighting this virus. Paint a picture of what the situation is like on the ground.
Yeah, thank you, Smriti. I think it's a great opportunity for us as the Doctors Union to be able to participate in this forum. So COVID-19, as my colleague has said, has actually, and as you have said, has actually exposed our healthcare system, and not just in Kenya but globally. It's actually a rude awakening for the political elite. It has exposed the decades of political corruption, the issues of chronic underfunding of the health sectors across the globe, insufficiently regulated, inadequately staffed, and the result has been poor health outcomes across the board, financial waste, increasing inequality, and disproportionate share of the global disease burden. But more essentially is that this is an opportunity to be able to rectify all these things I've said. And moving forward is that the health workers on the ground, which is now coming to your question, are actually strained as we speak, because we needed an increase in the number of healthcare workers. I think the process is yet to be completed and for them to be deployed across the ground. But basically, the health workers are motivated also to ensure that they serve Kenyans as they should. We empathize with the public, with the situation that we're all currently in. The mitigation measures have been tough on Kenyans, and that the COVID-19 pandemic is both an economic and a health crisis. So health workers are working in tough conditions. Of course, we've had issues of inadequate personal protective equipment, issues of strained and fewer workers on the ground. But these are issues that are now being addressed, issues of training, issues of psychosocial support for the healthcare workers. So those are basically the issues around that health workers are currently grappling with. Thank you.
To those who tend to attend clinics. Now, due to the fear of contracting this disease in health institutions, people are shying away from showing up for clinics, as Dr. Mercy also alluded to, from expectant women to children who need immunizations as well. And this has in some cases had tragic outcomes. And Kenya really could face a double blow if people fail to show up for their clinics. Sean, tell us why it is critical that people don't shy away from hospitals during this period in particular.
But thank you for the question. But before I answer that, I would like to basically have some discussion about the extent of the problem that we have in Kenya. And I would like also at the same time acknowledge our colleague from the Ministry of Health, the Cabinet Secretary of Health, my both colleagues basically, Principal Secretary Dr. Rashid Aman and Mercy. Today I did some analysis. I looked at South Africa as number 1 with the COVID, and Kenya as ranking number 16. Based on the numbers that they were basically published in the newspaper, we have a mortality rate of 3.7% in Kenya and 2.1% in South Africa. When you look at the recovered, our recovery rate here is 28%, and South Africa is the 52%. And the combination of the recovery and basically mortality gives us 32% in Kenya and also around 42% in South Africa. What happened to the other 68%? We don't know. Then the recent number of the test was 3,077, and 4% of those patients were positive. Now let's imagine if we have done 100,000 tests, we would have most probably 4,000 people positive. Now this number is important, and we need to understand the R value of the COVID. And what does R value means? It means if one person is infected, how many more people that person can infect. And these are some of the numbers that might be of interest, because it helps us to come up with the policy and how we're going to deal with this issue. For example, influenza R number is less than 1 or equal to 1. When you look at Spanish flu R value was between 1.7 to 2.7, and median was 1.8. When we look at the COVID, it's between 3 to 4, and the recent study says that the median is 5.7. What it means, 1% positive COVID can infect 5.7 more people. Any R value more than 1 basically create an exponential increase in the number of the patient. And the R value less than 1 basically says in a long term, you will have this disease to disappear. If this is the fact, then not having the capacity to test a lot of patients, it might create a wrong picture. And the biggest problem that we're going to have here is going to be community transmission. Now, when the fear is there, then the question here is what the patients are going to do. Patients, they consider the hospitals are basically the source of the infection, which in reality it is not. Being prepared to take care of the COVID patient, it doesn't mean you are the source of infections. And one of my comments to my colleague is many people, they go to grocery store. In the grocery store, basically some of them, they say, hand sanitizer, but when you walk in, you don't know who is healthy, who is not healthy. In a hospital like Aga Khan, when you come in, we measure your temperature, we give you a hand sanitizer, but the difference is I know the status of every individual that works here. They are healthy, they are not healthy. Now, by people avoiding coming to the hospital, they might endanger their long-term care. When we look at these people, we have basically 3 categories. We talk about children's, we can talk about the patients with chronic disease, then we can talk about basically maternal health. And each one has a consequences. If the patients or the children, they do not go for immunization, they might be suffering from the other contagious disease, okay? If they are not being assessed by their physicians about their nutritional needs, it might impact their ability, to develop properly and ultimately hinder their growth, okay? And there are unfortunately young patients that they are suffering of the non-communicable disease such as cancer, diabetes, heart disease, epilepsy, and they have to be regularly reviewed by their physicians. Patients with the chronic disease, by avoiding coming to the hospital, they can complicate their situation and end up in an ICU and ultimately pay more money for something that could be taken care of with simple medication. And then we have mothers, that they might have a high-risk pregnancy, and they need to be constantly also reviewed.
Right, Sean,
those are some of the barriers that this perception has created.
All right, thanks very much for that insight and also for those statistics. And that now brings me to Dr. Githinji. With regard to statistics and predictive modeling, that is what's being used to sort of gauge the direction in which the country is heading in. Tell us how predictive modeling is being used to manage COVID-19 in the country, and also what are the projections from the Ministry of Health based on predictive modeling?
Well, Let me start by saying that predictive modeling is basically scientific guesswork. You're guessing with some facts, with some assumptions, and therefore the challenge that I've seen is people looking at the models and the numbers we develop as if they are targets that we are putting to achieve. I want to make it very clear that when we are doing modeling and prediction of what the numbers could look like, they are not targets. They are our idea of if the assumptions were to be, for example, that you will lock down, based on what Sean was talking about, based on how many people can one person infect, and what do you need to do to stop that person from infecting that number that you assume each person can infect. You take some measures. Those measures could be reducing mobility of people, reducing the movement of people. That's why we do lockdown. That's why you do curfews. That's why you do all those things. It could be that you're testing and isolating people. So when you take these assumptions, are we doing these things or are we not doing them? If we were to do them, what would we expect to see in terms of the rate of infection? And what would we expect to see if we didn't do these things? It's purely an assumption based on certain variables that you have. Now, what we have seen is that the virus is always 10 steps ahead of you. And everything you do in a pandemic, we will sound alarmist because your predictions assume that things could go wrong at some point, and therefore you want to say we could end up with 100,000 cases, or we could end up with this number of mortalities, and therefore you overreact to ensure you don't get that. And therefore you want to always be behind your predictions. So what we've done now is, globally there are predictions. In Africa there are predictions. You've seen WHO saying, 40 million or more people, 40 to 100 million could get infected in Africa. We could get up to 100,000 deaths. These are not things that we need to wait for to happen. These are supposed to help government to then say, if that's the case, then what do we need to do to avoid those numbers? In Kenya, originally we had predictions from foreign, think tanks that said Kenya could end up with 10,000 cases by April or by May, 100,000 by this time. And journalists have kept asking us, why are we not achieving 10,000? Why are we not getting to 100,000? And I keep saying, and I like the Director General, keep saying, these are not targets to be achieved. They have helped the response. The reason that, the reason Kenya is where it is because we had those predictions. And therefore we said, if this could happen, then our health system could be overwhelmed. And therefore that triggered the task force, the national committee, the cabinet, the president, to then allow the measures to be put in place to avoid those cases. So in Kenya now, the modeling that I've seen, which is done by a team from the Ministry of Health, from certain universities, from Center for Disease Control, is that we may get a peak of cases by end of August, by early September. This is where the minister was saying we could get up to 200 cases a day. Today we had 147. So I actually personally think the 200 is underestimated, that actually we are going to see more numbers as we go, and we are going to end up with peaks. Remember that in all epidemics, in all outbreaks, diseases go up in a bell curve. They go up like this and then drop down. So what we are discussing is the peak, not the end. And that peak could be somewhere in September. But remember, these are not targets to be achieved. There are guidelines for policymakers to ensure that they have everything in place in case those numbers were to happen. So that's the long and short of it.
Well, the big question is, do we have everything in place? We certainly know that action has been taken, but still there is so much more that needs to be achieved. I'll be putting that question forward after this short break. Do stay with us. This is the Nation Leadership Forum. Much more when we return.
I'm here today to give you a few tips about how we're able to flatten the curve and curb the spread of this virus. Ensure you wash your hands as often as possible with soap and running water. Stay at home to protect yourself, your family and your loved ones. If you have to leave the house, ensure you wear a mask. And if you live with small kids, ensure they wear the masks too. While outside there, ensure you keep your social distance, which is 1.5 meters as recommended. In these difficult times, we are calling on brands and businesses to do good and give back. As a business, avail your resources and time to the less fortunate and help curb the spread of the virus.
It's okay. It's okay. Calm down. Mtosi yuko.
Nilisema mabati letwe.
Horse hasijaletwa.
You are calling cannot be reached.
Are you planning to build? Avoid such situation. Go into the Google App Store and download the iBuild app. Get accredited contractors. Get reliable suppliers for all your materials. And you will also be able to manage your projects using the iBuild wallet so that you can also know how your money is spent. Tujenge na iBuild.
Do your gums hurt? Yeah. Does your toothpaste contain sage, eucalyptus, myrrh, chamomile? All that in one toothpaste? Yes, try Colgate Herbal. Colgate Herbal contains nature's best herbs and Colgate's fluoride technology to give you strong teeth and healthy gums. Ah, Colgate Herbal. Let's go. Colgate Herbal for strong teeth and healthy gums naturally.
If we continue to behave normally, this disease will treat us abnormally.
You may feel weak when things look bleak. Be strong, 'cause you have it in you all along. When you believe, amazing things happen. When you believe, when you believe, let go and let those who know show the way.
We do amazing things at Aga Khan University Hospital, Nairobi.
When you believe.
Welcome back to the Nation Leadership Forum with me, Smriti Vidyarthi. Tonight we are tackling the issue about the impact of the coronavirus on Kenya's health care. My conversation continues now, and remember that you can also join in using the hashtag NMG Leadership Forum. Tweet me at Smriti Vidyarthi and at NTV Kenya. Before we took that breather, we ended on the note or the point that predictive models help us prepare. Dr. Mwangangi, I'll bring you back in now. And of course, if the curve is not flattened, there is no doubt that Kenya's health system will be overwhelmed, as we have seen in so many other developing nations across the country. Allow me to refer to some statistics. The doctor-patient ratio in the country is estimated at 1 to 15,000, yet the WHO recommends 1 to 1,000. And according to a study published in April, this was from an article in the Daily Nation, only 22 out of the 47 counties have at least one ICU unit. A study led by KEMRI said that the country would need an additional 1,511 ICU beds and 1,609 ventilators. to 374 ICU beds and 472 ventilators, depending on the transmission curve, to absorb caseloads due to COVID-19. Now, based on various data, really, what is the state of our preparedness when we talk about the worst case scenario, which could come at any point? Are we ready?
Great. Thank you, Smriti. And let me latch on to what Dr. Githinji said regarding our models and our predictive modeling. And he called it guesswork. And back in school, some of our lecturers have always told us that all models are inherently wrong and all models are inherently false. And so the important thing when it comes to looking at are we ready and are we prepared, it is in trying to determine what would the worst case scenario look like for Kenya. And I think Sean has been able to highlight for us, if we looked at our current testing rate and we extrapolated that with the population in the country, then it would be easy to say that nearly 1% to 2% of Kenyans are already infected. And that's about 1 million Kenyans already infected. Now, if we look at the data in terms of the learnings that we are getting from China and all other countries, we are told that largely a fair number of people remain asymptomatic and others have mild disease, so about 80% of these. So if we remove 80% from 1 million, we're left with about 200,000. 200,000 Kenyans, 5% of them would then have critical diseases that would require them to get critical care services. Now, are we ready? What I can say is that from the beginning of this pandemic to the 78th day, we've greatly improved in terms of our readiness, and primarily in collaboration with county governments. And our readiness has focused on 4 thematic areas. And the first one is our healthcare workers. And I'm glad that Dr. Chibanzi, who is a colleague, is on here today. And he did attest to the fact that when we began the COVID-19 response, we did have challenges. We had challenges when it came to PPEs. We had challenges when it came to healthcare workers in terms of ensuring that they are capacity built and that they are aware of how to manage COVID-19. We even had challenges when it came to case management. How shall we manage a moderate case? How shall we manage a severe case? How shall we manage a mild case? But a lot of gains, I'm glad to say, have been made 77 days on. For one, we've managed to train all our healthcare workers, particularly through very good collaboration with the Kenya Medical Association. We've deployed an online module that has been able to target healthcare workers, and they're able to get information on all our 19 protocols, which are governing how we manage COVID-19. Secondly, we've been able to deploy through the UHC program an additional 8,000 healthcare workers are under different levels of recruitment in different counties. And this will be essentially a boost to our healthcare numbers, and especially at the primary healthcare level where we feel it is most impactful in terms of trying to ensure that the community is part and parcel of our response. And additionally, through partnerships with members like Red Cross and AMREF, we've even been able to use mobile technology to ensure 60,000 community health volunteers are actually able to partner with us in this fight. And so when it comes to having the soldiers on the ground, we've been able to train them in terms of what they need to do. And secondly, we've been able to arm them with the necessary equipment, protective gear, in terms of ensuring that we protect them and they're able to offer care. And additional interventions have also been put in place in ensuring that our healthcare workers are best suited to be able to fight for us. Secondly, when it comes to health infrastructure, I'd like to latch on to what Chibanzi said, that COVID-19 perhaps has come with a silver lining. And for the first time, there's a huge focus on health and a huge focus on the linkages between health and the economy. And of course, in comes in health infrastructure. We've been able to conduct a very rigorous assessment of our health infrastructure in the country. And this has been through joint collaboration again with county governments. And we've asked ourselves critical questions. Do we have enough critical care infrastructure in the country? Do we have enough oxygen? Is this oxygen readily available to our patients, and especially the critical care patients? Do we have enough ventilators? Do we have enough ICU beds? And most importantly, do we have enough healthcare workers and skilled healthcare workers who are able to operate this machinery? And this again is a response that we are working on to improve. And indeed, I like that you quoted the study by Kemry Wellcome Trust. That was actually a joint effort with the Ministry of Health in trying to look at our ICU bed capacity. And since that study has been done, we've actually been able to procure more ventilators. We've actually been able to receive more ventilators from different partners and support from different collaborative efforts. And so right now, as we speak in the country, looking at our models, looking at our current response structure, we can definitely say that we've definitely made at least a substantive improvement when it comes to being ready for critical care services. I'm glad that the Council of Governors Chair, Wycliffe Oparanya, was most recently able to note that there have been great improvements even in isolation facilities at county level. I'm aware right now our bed capacity stands at 5,000. And if we were to look at our model, our worst case scenario, I've had a few models say that perhaps we may need 100,000 beds, and there are efforts underway to look and see how this infrastructure would be in place to ensure that we have an adequate COVID-19 response.
All right.
Secondly, we've been able to ramp up
Go ahead.
our communication. Sorry, Smriti. Just one last point. We've been able to ramp up our communication because, as everyone has said in the panel today, there is no vaccine for COVID-19, but there is what we are calling the social vaccine. And that's us Kenyans. You are actually the vaccine. And so the interventions that you put in play actually determine if we flatten the curve. And we strongly believe that behavior change and ensuring that Kenyans actually adhere to their physical distancing measures will actually help flatten the curve and will actually help the health system to be more resilient.
All right, so
thank you, Smriti.
Thanks, Mercy. So what I'm getting from you is that certainly there have been improvements. Are we ready or not? It seems like we don't have a solid answer to that question yet because we don't yet know exactly what the worst case scenario would be. But I'll bring in Dr. Chibanzi now because Dr. Mercy raised certain points that she said, all people on the front line or all health workers have been trained. She also said that they do have the necessary protective equipment, and also they're working hand in hand with county governments, and to an extent there has been a lot of improvement. Bearing that in mind, on the 23rd of May, President Uhuru Kenyatta gave an address, and this was about healthcare interventions. He talked about hiring an additional 5,000 healthcare workers with diplomas to respond to COVID-19. He talked about 1.7 billion shillings being set aside for the expansion of bed capacity in public hospitals. Also, he talked about resources being pumped into medical research facilities. Are you aligned with the Ministry of Health when they say that indeed strides are being made and there are big improvements?
Well, thank you, Smriti. I'd like to first acknowledge that the President has actually given direction and shown leadership during this COVID-19 crisis. I think he's given directions for specifically hiring more healthcare personnel and ensuring that healthcare workers have a welfare package, comprehensive insurance, treatment, and that healthcare workers are essentially comfortable and being able to combat COVID-19. And I also acknowledge my colleague, Dr. Mercy, that there have been efforts towards training, capacity building, but essentially is that there are still gaps that need to be addressed. Of course, there's been progress. One of the gaps is that as for PPEs, we still have inefficiencies, especially in the level, in the high-risk areas in the facilities. Remember, we have level 3 PPEs that are the full kit for the isolation and treatment centers. And then we have the level 2 and 1 PPEs for the triage areas in the facilities, the A&D areas, and the high-risk areas in the facilities. So there's a gap here when it comes to these workers that are still exposed. We're still experiencing cases of health workers who have to undergo quarantine because of exposure at the workplace. We still are yet to see an extensive and elaborate strategy on psychosocial support for healthcare workers. The testing that was launched, which was a very good thing by the Ministry of Health at the national level, but that is yet to be scaled down to the counties, and there are deficiencies there because a health worker, for instance, in Lamu or Mandera today, or even in Busia, doesn't have the correct, or rather where they should present themselves for testing. And we've had instances where the testing takes quite long. So there are gaps that need to be filled. But there's progress. Of course, on occupational safety and health, there's need for more emphasis on ensuring that the facilities and healthcare workers are well taken care of. We still have accommodation yet to be provided for those who are in the isolation and treatment centers, and a good number of the healthcare workers have expressed concerns of and worry where that they're still going back to their families, where some of them live with elderly parents, others have very young children. So these are still areas that need to be fully addressed. We still need issues regarding the welfare package. I think it's yet to be unveiled a month later since it was the directive was given. So yes, there's been progress, but there's more in terms of ensuring that the healthcare worker is well taken care of comprehensively so that they can be able to deal and be in the right mental frame in terms of psychosocial support to be able to take care of these patients. Because remember, there's burnout that is now setting in. We have also the moral injury. It's quite heavy duty seeing these patients every single day. And of course, where you've had instances of mortalities, then it takes a toll on the healthcare workers out of that care. So part of the psychosocial support would include debriefing sessions, psychological counseling, for them to be able to deal. And this is not just for COVID, this is even beyond the COVID period. These are instances that healthcare workers face every single day. So we do have a number of mitigation measures, specifically on the healthcare workers that can make the situation better and more bearable. We still are waiting, of course. We acknowledge that 8,000 workers and the diploma certificates and for the 5,000 that were announced have been hired. We still want more doctors hired to be able to work hand in hand with other healthcare workers. So essentially, there's progress, yes, but there's still more to be done to be at almost 100% of the healthcare worker being comfortable.
Chibanzi, thank you so much, and I will allow Dr. Mercy to respond to some of those issues that you've raised, but you talk about working hand in hand. Sean, I'll bring you in now because, of course, this virus requires everybody to work together, not physically and literally hand in hand, because we know that handshaking is something that is a no-no at this point. But private hospitals have a big role to play. Talk us through what the Aga Khan Hospital is doing in the fight against COVID, from managing those on the front line, its patients, but also when it comes to the bigger picture and fighting the virus itself.
Thank you for the question. We believe that as a private institution, we are complementary to all the efforts that our colleagues are doing in a public hospital. We are here to collaborate with the Ministry of Health and the public hospitals because the problem that we are facing is a problem of the Kenya and the nation. And we have to become complementary to each other. Our process here was just a little bit different. The first notice we sent out to our staff, it was in January 28, before even we had a positive case of COVID in Kenya in March 12th. And we went through a very systematic approach. We look at, for example, our disaster management plan, clinical pathway, and then based on the available resources that we have, which is 300 physicians, residents, house doctor, faculty, and more than 700 nurses, we are using the California nursing staffing ratio. We looked at it and see what is the maximum number of the patients that we can basically accommodate. We realized it's maximum 400. Subsequent to that, we have also arranged for the field hospital and increased our capacity by 100 beds. And then we also made guidelines. We want minimum 6 months worth of the personal protective equipment available in a hospital. As a result of it, we invested more than 200 million shillings to make sure we have all these personal protective equipment in the hospital. And we made a promise to our colleagues. Anybody that becomes infected with COVID-19, this hospital will provide them 100% care free of charge for them and for their family. And thanks God, so far we have not had any of our colleagues to be basically become a COVID-19 positive. The other thing that we are doing, we have ordered 20,000 tests. And we have right now just a little bit bottleneck regarding the extraction material. The new extraction material should be here by June 15th. And we will be increasing our capability for testing up to 200 tests. We decided to offer free COVID tests for any patient that wants to come to the hospital. They need to be hospitalized, they need surgery, day surgery, or for mothers that they will be expecting and for a delivery. We believe this will help us to become complementary to Ministry of Health. Because when we know the condition of the patients and we discover more people that they might be positive, we work very closely with our colleague, we report to them, we coordinate with them, and hopefully, we can together make a difference and create an environment that is safe for the patients and for the community.
So much. Let me bring in Dr. Kavinji now. As the Group CEO of AMREF Health Africa, what is AMREF doing in this fight against COVID-19?
So AMREF is a global organization. So in Africa specifically, where all our programs are, we are working in about 11 countries and also extending to another 35 countries through partnerships. And here in Kenya, also very, very actively. So let me just start from the top and say that first, we are at a very technical and policy level. So we see it on the governing board of Africa CDC. So I'm a board member there. And we also see it in the Africa Continent Steering Committee for COVID-19. So at a continental level, we are contributing our knowledge, we are contributing our experience to the continental response. But then at a country level, both in Kenya and also in the other countries where we have staff, which are about 12 or so, we are sitting in the national task forces. So in Kenya specifically, we are participating and assisting the Ministry of Health in the national task force, and specifically because of our history in ensuring that communities are actually integral to every health system. Remember that health is not made in the facility. Health is made in the household. And AMREF has always held that in every health response you have, whether it's an epidemic, whether it is the regular essential services, the community must be at the center. And we are driving a lot of community engagement, community health workers. So in Kenya specifically, if I was going to reflect, we are, together with others in civil society, including Red Cross, leading the community health pillar, or the community engagement pillar, within the Ministry of Health, within the Ministry of Health Task Force. And as Dr. Massey said, we are deploying our assets, which include mobile phone training platforms, which do not require internet. They only use text and voice, because many of the community health workers across the country do not have the capacity, the financial resources to buy data, to buy bundles. So we use text and voice, which they don't pay for. We get our donors and our partners to pay for, Africa CDC, Global Fund, and others. So this is one area we are working on in Kenya. So we've trained over 62,000 community health workers across the country to understand COVID and to understand how to respond to it. But beyond this, we are also supporting the government through what we call the National Business Compact for COVID-19. So we are co-founders in the National Business Compact for COVID-19, where we brought together many organizations, soap manufacturers, community organizations. Now we have brought in agriculture and nutrition, and our role there is to engage communities to put up hand washing stations. So within the National Business Compact, we put up close to 2,500 hand washing stations together with others, Rotary Fund, Rotary International included. And beyond that, we have created a fund that we call a flexible fund, which the Ministry of Health makes requests when they have urgent needs. Like recently, we flew to Mandera to assist the government to collect samples because there were security issues in Wajir and the samples could not be transported. So we flew there with our AMREF doctors to transport the samples. We have also assisted in management of quarantine centers, assisting in transportation of call center doctors. But beyond this, we are also assisting in procurement of PPEs. Through our partners like Rockefeller, we've assisted the Ministry of Health to procure PPEs that are being used specifically for care and treatment of health workers. So we have a care and treatment of health workers at Kenyatta National Hospital, which we've supported. We are going to be supporting Central Province through Odhaya's Level 6 Hospital as well, and across the country. So these are the things that, that we continue to do, including just sitting and listening and responding. But most importantly, our role remains not only within the Ministry of Health, but a voice in the community to ensure that this response is government-led but community-owned, because that's the only way that we are going to win. But beyond that, we're also doing a lot of communication together with the National Business Compact. The final thing we are doing is, through our AMREF flying doctors, through AMREF University, we continue to train health workers, as was talked about by KMPDU, Chibanzi, and Masi. We are training a lot of health workers and providing platforms like Jibu that actual health workers can go on their phone and learn about COVID-19, and also evacuating patients with AMREF flying doctors. We have recently invested in isolation capsules that can help us to transport COVID-positive patients when they need to be transported, and that we have already informed the government as a major partnership, because we are the only one who have that capacity, not only in Kenya, but in the region, to transport COVID-19 patients who are infectious by protecting our staff, the aircraft, and the people who receive the patients finally. So this kind of summary of our response.
All right, thank you so much, Dr. Githinji. As you say, government-led, community-owned. It really is our responsibility. On that note, we take another quick breather on the Nation Leadership Forum. Stay with us. We'll be back with plenty more when we return.
For a better tomorrow, don't forget to do the 1, 2, 3 with Colgate every night.
Oya ni aje, mimi ndio Jonte Fresh. Mimi ndio nimetambulika hii Gikomba yote sekta ya manguo. Jumio transform nguo ordinary za mtush zenye ziuka mna hii harufu ya Bale into the freshest Iggy kosi yote. Siri ni hii Real mpya ya pink. Na kushow mtushi zinang'ara kung'ara kushinda kamera. So clean, so fresh. Ma customer unaisana na hii story. Ninatumia Aerial Touch of Downy mpya tu.
Selena!
Toto, where is mommy?
Today's a toilet day.
What? Oh.
Selena!
Toilet day?
Tomorrow we're hosting a party and it's a matter of my reputation.
It's a toilet, not a white shirt. Even if you spend your entire day cleaning with bleach and detergent, it still won't be party ready.
Impossible.
Challenge. Harpic 10X. Even if you use bleach and detergent 10 times, they won't give you the same sparkling clean toilet that Harpic 10X will give you.
Wow!
Harpic 10X. Harpic, Kenya's #1 toilet cleaner.
Very simple. You want to work easy, get into Ivy. Tujenge na Ivy.
John suffers from indigestion. His twin James suffers from heartburn. Sometimes it's the other way around or both. That's why they use Gaviscon Double Action. It soothes within 3 minutes and lasts up to 4 hours. For double relief from heartburn and indigestion, Gaviscon Double Action. If symptoms persist, seek medical advice.
Disinfect and protect your home with Jik. Jik kills 99.9% of illness-causing germs. Disinfect floors, kitchen and bathroom surfaces, and wash white clothes, towels, and dishcloths with Jik bleach. Just Jik it.
This is NTV.
Tonight,
147 people have tested positive.
the number of infections is rising and the pandemic is taking a toll on healthcare workers.
As at yesterday, that number stands at 54.
Also tonight, desperately ill prepared for the worst.
Tumekuwa na wasiwasi, tumesema na hapa itakuwaje? Hapa Turkana kwetu hapa hivi.
The Kakuma refugee camp is a coronavirus disaster in waiting. Plus,
vile saizi mama yuko job juu ya pandemic, so ni ngumu. You sometimes unashindwa hata kutoka nje. Utatoka kujava but maybe pita watu anze kuchekelea kwa barabara.
The pandemic worsens period pain for young girls and women. And also tonight, the NASA coalition is also spring cleaning.
Kufuata makamu wa rais pia ni hatia.
Who's out and who's in?
I was born. I came out of my mother's womb without any committee.
Disinfect and protect your home with Jik. Jik kills 99.9% of illness-causing germs. Disinfect floors, kitchen and bathroom surfaces, and wash white clothes, towels, and dishcloths with Jik bleach. Just Jik it.
Kira! Kira? Where are you?
Malaria! That's why you need the superior protection of Mortein 360-degree reach. Only this has 11 fans which enable it to reach the farthest corners. Mortein, total indoor protection.
It's in times of great difficulty that we should always give thanks to those who are there for us. So, to all our customers who have been there for their friends, their families, those in need, as well as us, we'd like to say thanks. Thanks for staying at home and staying connected. We've got you with an automatic upgrade on us. A little gift from our heart straight to yours.
Blueband margarine. New look, same great taste.
The risk of illness-causing germs is increasing. It is believed that the coronavirus can remain on surfaces in your home for up to 9 days. Touching infected surfaces is one of the ways in which germs spread. Regularly disinfect your floors, countertops, and kitchen surfaces with bleach, and use an effective toilet cleaner inside and outside your toilet bowl. This message is brought to you by Medifact, Jik, and Hapik.
When you sit with a plate of food today, pledge to stand for someone who has put food before you. Dial *126# to transfer your bonga points now so they can buy food and necessities at any outlet with a Lipa na M-Pesa till.
Safaricom is for you. The Kenya Film Commission, in line with its mandate and function of promoting development of local content and establishing a film fund, has established a film empowerment program that will provide film and video-related funding. The Commission announces the funding application for the 2019-2020 financial year. Individuals, companies, and organizations will be required to submit funding applications to the Commission. The submissions kicked off on the 28th of April and will run through to the 9th of June 2020. To register, visit www.kenyafilmcommission.com. Kenya Film Commission. Film Kenya. Capture Africa.
Welcome back to the Nation Leadership Forum with me, Smriti Vidyarthi. We are focusing on the impact that COVID-19 is having on Kenya's healthcare. Now, I will allow Dr. Mercy to respond to some of the issues and concerns raised by Dr. Chibanzi. Dr. Mercy, Dr. Chibanzi said that while progress is being made, there are still gaps. There have been challenges in coordination between the county and national levels of government, for example, with regard to the procurement of equipment. There are issues of the welfare package for those on the front line. Some PPEs are not up to standard, and also not enough is being done on addressing the impact of COVID-19 on mental health. Your response to those points?
Thank you, Smriti. And recognizing that Dr. Chibanzi is actually one of the frontline healthcare workers, I'm happy that he's actually highlighted that, yes, there are challenges and there are areas of improvement. And perhaps that is why, if you have taken note, that the ministry now has shifted its focus towards the county governments and ensuring that we can actually now work and partner to highlight how ready we are. And today, the Cabinet Secretary, Mutahi Kagwe, was in Kiambu County. That is where he gave his address from. And that is part of our process in terms of shifting the focus from national government to county government and our collaborations. And yes, indeed, in the beginning, there were challenges when it came to PPEs. But I must say one of the most key lessons that we've learned is that there's need for self-reliance. And this has been demonstrated by the local manufacturing of PPEs. However, one thing remains a challenge when it comes to ensuring that we all have our healthcare workers kitted. It becomes necessary to ensure that we are actually having rational use of PPEs, and that these PPEs are used especially in high-risk areas, and that there's actually controls in how we ensure that we triage our healthcare systems and our hospitals to ensure that there's that level of protection. Secondly, the issue of mental health really is quite priority within the Ministry of Health and is of high priority, and initiatives have been made, one, to ensure that our healthcare workers actually have the support that they need. We've deployed a call center where our healthcare workers, one, are able to call in, dial in, and on the other end is actually another healthcare worker who is able to talk and relate with some of the challenges that they're going through. Secondly, we've had beautiful collaborations with some partners in the private sector. We've had UAP, Absa Bank deploy interventions that actually ensure that our healthcare workers can actually broaden in terms of the networks that they have in terms of psychosocial support. And thirdly, within the Ministry of Health, through a partnership with Madari Hospital, we've actually deployed our psychiatrists and psychologists to ensure that these people are available. We actually have a designated team of psychosocialists, especially just for healthcare workers, as opposed to the ones that are managing our call center. And these are there for our healthcare workers. Is this enough? Certainly not, especially noting that these healthcare workers are in a battlefield, and therefore they need the most support that they can get. And so what we're doing as a Ministry of Health is cultivating more resources towards this support. As we look at the different packages, particularly the NHIF cover, this will have elements of offering social support for them and ensuring that there's access that they need. And secondly, there was an issue that Chibanzi raised regarding the contact between the healthcare workers and their families. Yes, this was identified as an issue early on, and interventions were put in place. Remember, our healthcare workers are actually members of families. They're actually brothers and sisters and parents and grandchildren. And so we did deploy an initiative, and this was primarily led by the hospitals across the country, both nationally and in counties. And nationally, Kenyatta Hospital, KU Hospital, was able to designate accommodation facilities for healthcare workers who would rather sit within those accommodation facilities and not expose either their elderly patients when they go back, elderly parents or grandparents when they go back home. And these facilities are there, and some healthcare workers have utilized it. The request we made in terms of collaboration is that county governments extend these facilities and ensure that in all their isolation and treatment centers, that these accommodation facilities are actually available. And like I said earlier, the Ministry of Health has now changed focus. Our Cabinet Secretary has changed focus towards county engagement, and you will be seeing him moving from one county to another to be able to actually work hand in hand with county departments of health and ensure that these measures are in place. The third element that has been mentioned.
Go ahead.
Sorry, Smithy.
Go ahead to your third point.
Right. So the third point that has been mentioned includes capacity building and the numbers on the ground. We recognize that indeed, looking at our healthcare worker to patient population ratios, that we do not enough health workers on the ground. And we are working through the UHC program to recruit more. But additionally, there is also resources for adding on more doctors from all cadres, including the medical officers, but also critical care doctors like anesthetists, ensuring that they are actually in place. And these are initiatives that are underway and will soon be realized as we continue the recruitment process.
All right, thanks, Mercy. Now, you did mention the point about high-risk areas. And Sean, I'll bring you in here now because we know that there is at least one recorded case in the Kakuma refugee camp. And on our 9 o'clock news tonight, we will have a story about the situation there. Our highlight read, Kakuma refugee camp is a disaster in waiting. What is your insight into a situation where a refugee camp, which is packed with people, social distancing would be extremely difficult? How best can the government deal with that?
Is this question for me?
It is to you, Sean. I just like your perspective as the CEO of Aga Khan, what you think the best move would be for the government to address that situation.
You know, I believe the best move for the government is, as I mentioned, this is a collective responsibility of the private institution and the Ministry of Health, because this is a national crisis. It is not basically just government or private hospital. For example, some of the things that I can offer here is we do have a mobile clinics. And I will be more than happy to make, for example, our mobile clinics available to the Ministry of Health and provide up to a reasonable amount of resources that they might need and educate people regarding how this COVID basically gets transmitted from one person to another person, do an assessment of the infrastructure, and see how we can collectively work together, you know, to mitigate some of this risk. Because when you have a high density, and based on number that I gave you at the beginning of our discussion, if we believe that the R value for COVID is 3 to 4, and one person can infect 4 people, then you can see how fast it can get out of the hand. And then after that, it's going to spread towards the rest of the city. My perspective here is we need to all work together because it becomes everybody's problem. And I'm here to make offer to Mercy. If there is anything that Aga Khan University Hospital can do by providing some supplies or mobile clinic, I will be more than happy to do so.
John, thank you very much for that commitment, and I'm sure it will be greatly appreciated. And I'll come to commitments from the entire panel towards the end. Dr. Gidinji, I'll ask you a question now. What do you think this COVID-19 pandemic has taught us about the investment in healthcare in Kenya? It clearly has never been a priority, has it?
And Smriti, it's global actually. We have had a major challenge globally with health investment, commitment to health investments. And I think I made a remark the other day that COVID has come to take away by force what we have been reluctant to do or to give for the health sector. We know very well that we have talked for a very long time about the link between universal health coverage and health security, where health security is exactly the ability of the health system to respond to an epidemic like this or a pandemic like this in every country across the world. But we've seen that this test has not only failed here, it failed globally. We've seen Germany, we've seen Italy, we've seen the disaster in the US. But if you look at most of these countries, you will see that pandemics like this or epidemics like this affect the most vulnerable most. If you have to start with the US, you'll see the people who are being affected are Latinos, Black people, the vulnerable communities, they are the ones who are actually getting affected most. When we come back here in Kenya, you will see that actually, because of the absence of universal health coverage, which means basically that everybody has access to a basic essential healthcare package without having to worry about how to pay for it, which then also puts money into the health system. You have two things on to create a good health system. First, you have to give people the ability to seek healthcare when they need without financial difficulty. But then you also have to strengthen the health system through all the factors, health workers, commodities, information and data. And because we haven't done this adequately, it means that our curve has to be flatter than the curve of any other country that has actually invested in healthcare. So we are seeing this as actually as catalytic to the conversation on universal health coverage. We are seeing this as something that will give new momentum to the government. And therefore, even as I speak here to my colleague Mercy and speak to the policymakers, because as civil society, we put pressure on government to ensure that equality is the approach, equity is the approach to health access. So my call is that this is the time we should be redoubling our efforts to ensure we achieve universal health coverage right now, not to wait when COVID ends, because COVID is going to be endemic. It's going to continue. It's going to continue putting pressure on health facilities. It's going to continue putting pressure on people's livelihoods. And health costs is actually one of the things that makes people poor. 1.5 million people in Kenya alone become poor because of health bills. You can imagine how it's going to go with people being tipped into poverty by COVID-19. We must now put universal health coverage as a priority, not after COVID, but during COVID. And that's what we want to see: investment in NHIF, investment in health workers, investment in community health workers, who we have refused to pay for a very long time. But yet, when it comes to this response, when it comes to what the President and the Minister of Health has said, and what Mercy has said, it is social vaccine, it is people. That's not going to be driven by government announcements. It's going to be driven by community ownership, deciding they're going to wear masks, they're going to wash their hands, and the agency for that is community health and taking health to the people, because the fallacy, well, I had today in an earlier webinar, that health is contained in the facility is purely a fallacy. Health is made at home, and that's where the response for COVID-19 is going to be. And therefore, the investment for UHC must start at the household, community health workers, primary health care, building up secondary and tertiary care.
All right, Dr. Chibanzi, are we ready for this lifestyle change and a change in behavior? Already what we're seeing 77 days into this pandemic in Kenya is a lax attitude. People are getting more concerned about their pockets, understandably, than their health to an extent. This is not only a health crisis, it's becoming an economic crisis, as we're all aware. But it does mean that our attitudes have to change. Are we there yet?
Yeah, so Smith 3, that question brings forth what I said earlier, and I'll reiterate that SARS-CoV-2 has no regard for social class, political class. So it means we're all vulnerable, and that it's a crisis that is both economic and health. And of course, where people feel that their economic situation is getting worse, then they'll want to get back to their normal activity. So the challenge here for the government is that it's an eye-opener to set up a robust social protection mechanisms to ensure that even the most vulnerable people in our society and in Kenya in general at least have some level of cushioning financially. And beyond that also is that there is need for certain measures to be taken. We keep seeing and essentially that UHC is a big four agenda. So I actually support what my colleague Dr. Gitai has said, that this is the time, this is the opportunity to ensure that we implement universal health coverage, which essentially just has 4 pillars. A well-motivated, well-trained, health workforce, ensure that there is a financing strategy, of course, increase the healthcare financing in this country to the 15% Abuja Declaration, where African countries actually committed to ensure that they finance their healthcare system. That is part of health system strengthening, ensuring that Kenyans are financially protected when it comes to healthcare services. That is UHC, the whole cornerstone of UHC. And the fourth thing is that for the 2 levels of government, I think as even yesterday we saw the Council of Governors coming out and uploading a Court of Appeal decision about the healthcare function being devolved. This conflict between the two levels of government, which is still here, is actually hampering service delivery. It is affecting on the healthcare workers. So essentially, as a union, what we've always said, and I'm glad that now we're having discussions around the referendum, that this is the opportunity to ensure that we have a centralized, coordinated management of human resources for health through the creation of a health service commission. So essentially, Kenyans, if are assured of a very strong healthcare system through what I've just said, they're ensured that there'll be financial protection, then they wouldn't have to worry much about that and about them going back to work. If there was a proper social protection mechanism from the government, I think Kenyans will be much at ease and be able to comply much easier. So to Kenyans, actually, we urge that you first take the responsibility yourself. Yes, we understand and we empathize that as healthcare workers that the situation is very difficult, but it is our collective responsibility and effort that will help us get out of this much faster, as opposed to not adhering to the mitigation measures that the Ministry of Health has actually been putting in place and kept emphasizing on. Thank you.
All right, thank you. We need to close this conversation shortly. I'll just go back to Sean. In the meantime, I'd request that you all think about your commitments that you will make on this Nation Leadership Forum. Sean, you already committed your support to the Ministry of Health as the Aga Khan Hospital to provide mobile clinics where available and where possible. So since you have already provided one commitment, what is your parting shot? What is your message to Kenyans briefly, as we're short of time?
You know what? My message to Kenyan is Aga Khan University Hospital has been 60 years here and served the Kenya. It's a Kenyan institution. And my comment or my commitment is to help as much as I can. But I believe as a nation, when you are resource constrained, we have to become innovative and self-reliant. Because I don't think so when the going goes tough, everybody is going to come and help us. In order to get that point, we need to forget about the differences, and we need to, as I said, become complementary to each other. No institution is perfect. There are challenges in Ministry of Health. We have our own challenges. My colleagues that they are part of panel, they have their challenges. But if we work together, we can create synergy, and collectively we can make a difference. And that is my request from everybody, okay? Let's work together to overcome this temporary problem, and then we can have a further discussion about the policy matters. What is the best way to provide equitable, affordable healthcare for all the Kenyans?
Sean, thank you very much. Dr. Kidinji, I'll come to you now. Briefly, your commitment, if you can, or your parting comment.
For me, the one thing I would like to say is that whereas a lot of our activities have changed to respond to COVID-19, the community needs have not changed. The community are still getting cholera, they're getting pneumonia, mothers are getting pregnant, young people want, people want family planning, people want to plan their families. So these things haven't changed. So for me, my personal commitment, the commitment on behalf of Amref Health Africa, the commitment on behalf of civil society is to ensure that in every conversation, the community is put at the center, that the community is the one that owns the response. And we will continue to do so, not only in the response, but also in the building of universal health coverage to ensure that the community is at the center. It is the center of gravity for sustainable response, because eventually, when the curfews and lockdowns and all these things are removed, it is the people who will exercise what Dr. Massey calls social vaccine. It is the individuals. So our commitment is to continue with that mantra in both word and action.
Thank you very much, Dr. Kidinji. And over to you, Dr. Chibanzi, for your commitment as KMPDU.
Yeah, so our commitment as KMPDU is one that will keep our health workers working in this time of the pandemic. We understand the difficult times. Despite the challenges we are facing, we basically have kept continuously our health workers on the ground to ensure that they serve Kenyans. The second is that as a union, we have partnered with several organizations. That's one of the commitments. We'll partner with organizations that have innovative ideas. We recently had a COVID-19 disinfection tunnel locally assembled, and the organizations are basically from Kenya. So that we see as a step in ensuring that we reduce infection prevention. It has now been donated and installed at the Moi Teaching and Referral Hospital. So if that can move across the entire country, then that will be a step forward. We are committing that we're going to train our health workers on occupational safety and health to ensure that they are safe, protected, and that they are well taken care of in response to COVID-19. And lastly is that we will keep this collaborative effort between us, the unions which represent the healthcare workers, and the government that is actually steering this COVID-19 response.
Dr. Chibanzi, thank you very much. And finally, Dr. Mercy Mwangangi, your commitment as the Chief Administrative Secretary at the Ministry of Health.
Thank you, Smriti. They often say that when life hands you lemonades, when life hands you lemons, then you need to make lemonade. And really, COVID-19 has given us some very bitter lemons, but we have an opportunity to make lemonade. And our lemonade ingredients include one, self-reliance. We've learned we need to be self-reliant as a country, and I'm glad to say the Ministry of Health is making steps towards self-reliance, beginning with PPEs, but also extending to local manufacturing of basic equipment. The second ingredient of our lemonade is collaboration. And I do thank Sean for extending support in terms of collaborating. And we need to see more of this collaboration with both state and non-state actors. And our third ingredient is a social vaccine, community participation, and whole of society approach. And the most beautiful thing, and perhaps today I'm an orator, would be that the jug that serves this lemonade is UHC. UHC is the priority. UHC is a vehicle that will actually help us flatten this curve. Thank you, Smriti.
Dr. Mwangangi, thank you very much. To all my panelists tonight on the Nation Leadership Forum, thank you for your contribution and for your commitments. And we will certainly ensure that those commitments are upheld. It's been a pleasure. Thank you for your insight. Well, that's all we have time for on this edition of the Nation Leadership Forum. I'm Smriti Vidyarthi. Do stay tuned. The 9 o'clock news is up next with Zainab Ismail.